Collaboration Program Fieldwide webinar on enhancing behavioral health and criminal justice partnerships through cross-training. To allow for additional sign-ins past the hour, we will be starting this webinar in a few minutes. Good afternoon. Thank you for joining today's Justice and Mental Health Collaboration Program Fieldwide webinar on enhancing behavioral health and criminal justice partnerships through cross-training. My name is Ethan Kelly, and I am a Senior Policy Analyst at the Council of State Governments Justice Center. I will be moderating today's webinar, which is hosted by the U.S. Department of Justice, Bureau of Justice Assistance, BJA, and the Council of State Governments Justice Center. To give you an overview of today's webinar, first we will do introductions of our panelists and organizations and provide an overview of the concepts of collaboration and cross-training between behavioral health and criminal justice partners. In addition, we have two guest sites speaking today to discuss their on-the-ground efforts building partnerships between agencies to improve responses for people with mental health and co-occurring disorders who encounter the criminal justice system. And toward the end of the webinar, we'll have time for questions and answers. A few housekeeping items. Anytime during the webinar, you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we will keep a running list and address them at the end of the webinar. We will do our best to get through as many questions as possible. If you encounter technical or audio problems during this webinar, please call WebEx technical support at 1-866-229-3239. Please understand that there are some technical issues that you may not be able to resolve. We are recording the webinar, and we will be able to send a link to the recording out to attendees by the end of next week. For introductions, Sheriff Kevin Coppinger came into office in January of 2017 after serving 33 years in law enforcement. His career began as a police officer in the Lynnfield, Massachusetts, before transferring to the Lynn Police Department in 1985, where he moved up through the ranks to become police chief in 2009. He then held that position until assuming command of the Essex County Sheriff's Department in 2017. As Sheriff of Essex County, he is committed to further professionalizing the Sheriff's Department by improving staff skills, training and accountability, expanding mental health services and medication-assisted treatment to confront the opioid epidemic, improving reentry programs and community follow-up, and by strengthening collaboration with other sheriffs, public safety leaders, community groups, and organizations. Sheriff Coppinger is an active member of the Massachusetts Sheriff's Association, Major County Sheriffs of America, the National Sheriff's Association, Essex County Chiefs of Police, International Association of Chiefs of Police, the Police Executive Research Forum, and the Federal Bureau of Investigation's National Academy Associates. Dr. Melissa Neal Stein is a Senior Research Associate at the Policy Research Associates Incorporated, where she provides research, technical assistance, and training services. She directs communications for SAMHSA's GAIN Center for Behavioral Health and Justice Transformation, which involves the creation and dissemination of national webinars, e-newsletters, and publications. She leads technical assistance projects, which previously included the Data-Driven Equity Inclusion Learning Collaborative, SAMHSA's Assisted Outpatient Treatment Grant Program, among others. She also provides sequential intercept model mapping workshops and train the trainer workshop for PRA's trauma training for criminal justice professionals. Her areas of focus include medication-assisted treatment in justice settings, racial equity in the criminal justice system, community health, including crisis response and early diversion, data and information sharing across criminal justice and behavioral health systems, and more. Wayne Young is the Chief Executive Officer of the Harris Center for Mental Health and IDD, the state-designated local mental health authority and local intellectual and developmental disability authority for Harris County, Texas. As the CEO of one of the largest behavioral health and developmental disability care centers in the nation, Wayne is passionate about the planning and delivery of behavioral health and intellectual and developmental disability services to a population who rely upon safety net systems of care. Wayne was recently honored to have been named to Modern Healthcare's list of top 25 innovators and to have received the 2019 Charlie H. Shannon Advocate for Justice Award from NAMI, Texas. Thanks to you all for joining the webinar. I'm going to give you some background on the Council of State Governments Justice Center. The Justice Center is a national, nonprofit, nonpartisan organization that combines the power of a membership association representing state officials in all three branches of government with the expertise of a policy and research team focused on assisting others to attain measurable results. Our staff develops research-driven strategies to increase public safety and strengthen communities. This slide describes a bit more about our work style and how we strive to reflect Justice Center core values, which include a commitment to being independent and nonpartisan in every aspect of our work, providing rigorous, trusted, high-quality analysis, developing practical and innovative solutions informed by data and research, promoting collaboration and building consensus, and being inclusive and respectful of diverse views and experiences. As an organization, we focus on a range of areas within the justice system. We pride ourselves in having a deep understanding of the experiences of people at the front line of the justice system and our ability to gather people from both sides of the aisle and across the country to foster collaboration. We promote smart and effective policy and practice changes through in-depth data analysis, on-the-ground training, direct assistance to state and local agencies, and dissemination of best practices and research. We do this work with funding through the Bureau of Justice Assistance and the Office of Justice Programs, which we would like to tell you about. At BJA, the mission is to provide leadership and assistance to local criminal justice programs that improve and reinforce the nation's criminal justice system. BJA's goals are to reduce and prevent crime, violence, and drug abuse, and to improve the way in which the criminal justice system functions. In order to achieve such goals, BJA programs illustrate the coordination and cooperation of local, state, and federal governments. BJA works closely with programs that bolster law enforcement operations, expand drug courts, and provide benefits to safety officers. Please visit the BJA website to learn more. The Justice and Mental Health Collaboration Program, or JMHCP as we call it, was established in 2005 and is funding the training today for the field at large. Some of the attendees may currently have a JMHCP award or may have received one previously. Through the JMHCP, BJA aims to help states, local government, and tribal organizations improve responses to and outcomes for people with mental illnesses or co-occurring mental illness and substance use disorders who come into contact with the criminal justice system, and support public safety by facilitating collaboration among the criminal justice, juvenile justice, and mental health and substance use disorder treatment systems. And with that, I will turn it over to Dr. Stein, who will introduce her organization and start off the presentations for today. Dr. Stein.
Thank you. So again, I'm Melissa Stein, and I'm calling in today from Policy Research Incorporated, which is a nonprofit that offers technical assistance training, research, and policy services. And so we are a sister nonprofit of Policy Research Associates, which is a women's-owned small business that leads in behavioral health and research. And PRA offers a number of services to help people with behavioral health needs achieve recovery. Some of the featured projects are the SAMHSA's Game Center for Behavioral Health and Justice Transformation. Also, we have the SAMHSA's SOAR Works, SOAR TA Center, as well as SAMHSA's Service Members, Veterans and Families Technical Assistance Center, just to name a few. And so today I'm providing more of an overview of behavioral health and criminal justice partnerships and cross-training, and then we'll be able to get into some of the local work that's done to apply some of this information at the local level. And many of you probably are very familiar with the need for collaboration if you're chiming into today's webinar, and that covers different approaches to individuals with mental illness or substance use disorders, conflicting processes, competing priorities, as well as limited funding. However, we've seen at Policy Research, as we've worked with jurisdictions across the country, some of the most effective programs and some of the jurisdictions doing the best work have some of the strongest collaborations. So we really consider this a critical component of creating a system and a program that produces the ideal outcomes. And so as we see collaboration, we see increased service integration, and from there, increased rates of service retention, stability in the community, as well as public safety. Now, the challenges with collaboration often mirror some of the need for collaboration, and so limited resources being one of the key challenges to collaboration, and we see partners being really protective not only of funding sources but also of the expertise and staff in their organizations. And we also see funding silos contributing an issue where you may have funds that are allocated specifically for certain projects and cannot be moved over for collaborative efforts. And then finally, we see system cultures where systems come with their own history, their own language, values, and operations, and that can also hinder collaboration. But as you're starting to think about forming or enhancing your collaboration, we recommend starting with the professionals, people with lived experience, and family members across the three key areas: criminal justice, mental health, and substance use treatment. And I really want to emphasize that the people with lived experience and their family members are very important. As I worked in Mecklenburg County for years, I was very familiar with the criminal justice system. It wasn't until I had to post bond for a family member that I came face to face with some of the real challenges that the community is encountering as they engage with the justice system. And so really having that lived experience or being a family member will provide a wealth of insight that you will never see as a professional. As you begin to build that collaboration, it'll be important to include other supportive agencies and partners, including social services, benefits and entitlement, housing, veteran services, and health. So here I have some of the key elements, key elements of collaboration. And so really these are the bones or the core components of collaboration. And collaboration really starts with commitment. So a commitment to starting the process, coming to the table, beginning the dialogue around some of the issues being faced, and also a commitment to some broad goals. So, really starting to develop some shared goals. Generally, improving recovery means reducing justice involvement and vice versa. So as different partners start to come together and commit to the work, they can quickly realize there are some shared goals, very broad shared goals that we can begin working towards. And as the dialogue continues, really a discussion of terminology and language will begin to emerge. And what means one thing to behavioral health partners might mean something different to criminal justice. So one community I worked with, the term diversion was actually defined in legislation, and so it meant something very specific to criminal justice partners. It meant something different to behavioral health, and so they had to engage in a conversation about that and create some terms that help them communicate effectively. As you are beginning to build that dialogue, you're going to see some trust building develop, and out of that, you can start to create some ideas of shared programs and shared solutions to the issues you're encountering. And as those programs emerge, really you'll want to start thinking about cross-trainings. I've got several slides around cross-training, so I'll get more into that later. Regular cross-system communication, whether that's meetings, reports, etc., are also a really important part of collaboration. And then finally, shared data is a major component, and I'll get into shared data further in the later slides. So I've already covered some of the elements of collaboration, and here are some more details to really enhance those elements. The first element was commitment. And so a big part of commitment is taking ownership of the work. In many communities, we see that as task force or as committees designated to fostering that collaboration and overseeing any programs that come out of it. You may also have boundary spanners. So these are people that effectively communicate across systems. They may know the language of behavioral health and criminal justice. And so those are people to set up and to really help take ownership of the work. And then finally, people with lived experience. So people who have lived through this, they have very different motivations and commitment to owning the work and ensuring that people behind them don't experience some of the same gaps and issues that they encountered. So they're really important as part of the ownership. So I already mentioned routine meetings. This can look like task force meetings, but in some jurisdictions we see case staffings where partners bring specific cases with clients to the table and discuss them. And as you do that, you can begin to identify common themes that emerge from case after case. And from there, you can start to develop some solutions around issues that are impacting many clients and cases. And then community meetings is also really important. What a task force might think is a solution may not necessarily work from the community perspective. And so it really is important to do this also in collaboration with the community to ensure that this is going to be an effective solution. And then regular ongoing cross-training, and again, I'll get into that more in later slides. Also part of the commitments element of collaboration can include interagency agreements. And so these agreements can cover coordination of services, they can clarify expectations around communication, as well as expectations and parameters around data and information sharing. So that can be sensitive sometimes. So having in writing exactly what will happen to data, how it will be shared, that can really ease concerns and foster collaboration. These agreements can also include org charts to clarify who's responsible where and can reduce duplication of efforts. And then around data sharing, this can look like regular reports where agencies will need to designate staff to pull, clean, analyze, and report the data. Some communities also develop dashboards to streamline that process and to automatically have available to partners information about people with behavioral health disorders interfacing with the justice system. So now I'm going to get into the cross-training, and there are a few benefits and goals I want to just make sure you're aware of. So the behavioral health and criminal justice systems are complex, and so cross-training can be really helpful to clarifying exactly what goes on when people are interfacing with both systems. And cross-training is also a great opportunity to build rapport across criminal justice and behavioral health partners. I've seen situations where a law enforcement officer begins to tell a story about an individual in crisis and really explain some of the challenges. And then I've seen beside him a behavioral health clinician saying, oh, I completely understand what you mean. I wish we could do X, Y, Z. And then right there, the law enforcement officer and mental health clinician have this shared connection. They understand a shared challenge, and they just automatically begin troubleshooting and exploring, how can we resolve these issues? So it's a really effective way to build rapport. Cross-training is important for developing those common definitions and the shared language I described earlier. And out of all of this work can really bubble up or emerge some mutually beneficial solutions to address your community's needs. Also, out of these conversations can come some strategies to increase the efficacy as well as the effectiveness of your programs. Now, there are a number of different strategies to accomplish cross-training. In some jurisdictions, we see criminal justice agencies inviting behavioral health partners over. They're doing a PowerPoint, they're just presenting on their practices and processes. That's one way, or vice versa, behavioral health inviting criminal justice partners over to present. And so this can be really helpful to do at orientation for new staff periodically on a regular ongoing basis, and as well as to address any special topics that emerge. For example, some jails are interested in implementing medication-assisted treatment, so that might be a special topics cross-training to hold across behavioral health and criminal justice partners. We also see as another cross-training strategy, members of both behavioral health and criminal justice attending trainings together. So you might see crisis intervention team trainings involving partners from both systems. And we also see that's effective members from both systems going to workshops and conferences together. And so those, while also educating them at the same time, it also gives them an opportunity to have some informal conversations and get to know each other and develop trust. Cross-agency visits and walkthroughs are really effective. We tend to assume that we know what's going on, but really walking through those services can clarify. And if you have a resource that's being underutilized, such as a detox center, having law enforcement come and walk through that detox program. What does it look like to drop someone off? How quick is that process? What are the steps taken to ensure that that person who's dropped off is adequately, addressed and isn't released until their needs are resolved. So, having people do some walkthroughs can really increase that collaboration and use of existing resources. Process mapping workshops and meetings. You see the sequential intercept model mapping workshops listed on your slide, and that's something that we offer at Policy Research Incorporated. And this can often, when we do this workshop, we're walking jurisdictions through the various points of intercept through the justice system, so arrest through community corrections, and we're discussing resources available to divert people into treatment or services. And what we found is often those workshops are the first time that behavioral health and criminal justice partners have come together to discuss their local system. And so that's extremely surprising to me every time I hear it, but it's not unusual. So including both partners in process mapping workshops can be incredibly insightful and a great cross-training opportunity. Ride-alongs or other shadowing activities can also be effective. In one jurisdiction that was facing issues related to their people in crisis coming into the jail, they decided to have behavioral health partners do ride-alongs with law enforcement for 6 weeks before they would even discuss a potential solution. But because of that 6 weeks of ride-alongs, they were able to create a really interesting and innovative solution to help stabilize people in crisis in their community. And then finally, site visits to evidence-based or promising programs can be really effective. There, you're going to send behavioral health and criminal justice folks over to another place that's implementing an evidence-based or promising program, and that can also inspire a lot of great conversations and cross-learning, cross-systems learning. So I mentioned earlier some process mapping workshops being helpful, and here I just have a few examples of process maps. This one is just a process map of the general justice system. What does it look like for someone to come in and go through the various pathways? And I think it's important to remember, even your justice system partners may not understand the full continuum of the justice system. They may be experts at their intercept, so they may be experts at the court process, but they don't necessarily know what's going on in the jail or community corrections. So doing a cross-training exercise to create this process map together can be incredibly insightful. This map is one that's generated out of the sequential intercept model mapping workshop that I've referenced before. And here, as you see, there are a number of intercepts where people may engage with the justice system, and we have listed out here various resources for diverting people into treatment or services. And this was created as part of some work that I did when I was at Mecklenburg County in North Carolina. And so I invited behavioral health and justice system partners to do this together. But I'll tell you, my behavioral health partners were reticent to join. They said, we're always joining your work to reduce the jail, the number of people coming into the jail, but we're really interested in diverting people from the hospital emergency department. And so in order to foster collaboration with my behavioral health partners, I promised them that we would take the information from this map and create another map, which is here on your slide. So this map was created to enhance or support diversion from the hospital emergency department. And it lists out the same resources that are on the previous map, but it just maps them out based on where a person might be in terms of being at risk of or in crisis, and what are the appropriate resources for them. And so that alone is an example of how to foster collaboration by ensuring that each partner can get the resources and products they need out of the workshops that you do together. When you get into doing cross-trainings, you might wonder, what are we supposed to cover or talk about? And Council for State Governments Justice Center has produced a really helpful publication. It's listed here, Police Mental Health Collaborations, a framework for implementing effective law enforcement responses for people who have mental health needs. And there's a link here. So this publication lists out a number of wonderful cross-training topics. So I'm just going to highlight a few here. So one of the most important issues to talk about on cross-trainings is stigma. And so we're still seeing across behavioral health and justice systems, there is still a significant stigma, particularly in relation to people with substance use disorders. And it still surprises people, but we're even seeing stigma across our substance use treatment providers. And so addressing stigma is a really important topic in your cross-trainings, as is discussing trauma-informed responses. So, empowering all of your partners to incorporate trauma responses in the work is an important one to talk about in cross trainings. As you begin to work together with your partners and perhaps do some collaborative co-response in the field, trainings on scene assessment and response protocols can be helpful. So that can include active listening and nonverbal communication, crisis de-escalation, stabilization, and mediation skills. And it's really important to begin to just build in this expectation that if someone is just acting unusually or as we would not expect, just go ahead and convert over to crisis de-escalation mode and assume that you may need to stabilize or mediate a situation. And then also important as part of cross-training is really discussing and understanding how to keep all partners on the scene safe. And then finally, you may want to cover some resolution resource options. So here I do want to highlight the importance of discussing peer support in your cross trainings, and having those people with lived experience is important, not just as part of cross trainings and collaboration, but it's important to also think about how do we better incorporate people with lived experience in the solutions and services that we're creating. I also want to just briefly highlight the military personnel and veteran resources. Don't forget about the families as well. With military, we are seeing increased domestic violence situations. We also recognize there are substance use disorders among veterans, particularly those prescribed opioids due to ongoing pain issues. And so keeping in mind that those could be some really helpful topics to discuss at a cross-training. And then finally, as you move through some of those basic topics, here are some more advanced topics. And the main one I want to emphasize is the data collection and demonstrating program success. So as you start to create and implement solutions or programs, you really want to create an opportunity to ensure everyone's on board with evaluating those resources and solutions. And then just a couple more cross-training topics here. Just want to emphasize the motivational interviewing can be a really interesting way to collectively increase the skill set of both criminal justice and behavioral health partners. And then finally, just want to remind you that the perspectives with people with lived experience and their family members is really important. And also, it might be helpful to think about opportunities to foster peer-to-peer learning. So where if you have a sheriff who is more resistant to thinking about behavioral health solutions inside the jail, link that sheriff with another sheriff in a different jurisdiction and let them have a conversation, and that peer-to-peer learning can be really powerful. So just briefly going to touch on collaboration and data sharing. This can look like just sharing blinded agency data, which still takes staff time to pull, clean, analyze that data. You also might want to think about how do we safely and legally share client data in accordance to HIPAA and 42 CFR Part 2 regulations. And you would want to think about those two things in terms of answering some questions. How can protected health information go to law enforcement? How can it go between jails and treatment providers, and so forth? And while we don't have time to get into this too much today, I do recommend a resource. If you look on the Substance Abuse and Mental Health Services Administration's website, you can just search for the SAMHSA store. They have a resource called Data Collection Across the Sequential Intercept Model, and it provides a wealth of information about collaboration and data sharing. So just recapping key elements of collaboration, again, the commitment, shared goals, language, programs, cross-training, regular communication, and shared data. And just recognizing consistency is key. In order to foster these collaborations, you're going to have to regularly contact, have those meetings, really revisit the issues. People are busy, they're distracted with the work of their programs, so you're really going to have to make an effort to pull people out of their day-to-day work to work on the long-term collaborative efforts. Top-down support is really important. If you only have a bunch of mid-level managers collaborating and creating solutions, but then the leaders of their agencies aren't interested in funding or implementing those solutions, then you're not going to get anywhere. So you have to make sure that key top stakeholders are in support. And some of the best collaborations we've seen have the support of county commissioners, county managers, and city managers. Don't underestimate the power of building trust. That's a really big component of collaboration. It does take time, but again, some of the best collaborations we've seen across the field have collaboration at its center. So don't be deterred and keep at it. So with that, I'm going to turn the presentation over to Wayne Young.
Great. Thank you very much, Melissa. I appreciate the opportunity to be here with everybody this afternoon and talk a little bit about our approach to training and cross-educational activities and the impact that it has on our system and the other collaborational impacts as well. So I will advance the slide here and talk a little bit briefly about the Harris Center. So we are the local mental health authority for Harris County. A little bit about our mission and vision. Essentially, I should have mentioned we are also the local authority for intellectual and developmental disabilities. We take that role seriously. Harris County, in case you're not familiar, includes the city of Houston. So we're a large community. Our population in Harris County is about right at 4.8 million, between 4.8 and 4.9. It would make us the 26th most populous state if we were a state. We have services in a variety of divisions: forensic, regular community mental health, a fairly large footprint. In a typical year, we serve about 80,000 unique people with serious mental illness and intellectual and developmental disabilities. We are also delivering that care at over 87 care locations with 2,350 dedicated behavioral health and IDD employees. It gives us a pretty large footprint and a very large community. And despite all of those numbers, like many of you who work in behavioral health, it feels like there's never quite enough, right? The resources don't always seem to quite match what the needs are. But we're excited about our mission. We do serve a safety net population of individuals who have a serious mental illness and have little other care options in our community. So a little bit, I'll pop back here real quick. So the thing I also want to emphasize as I talk about that size and scale is the fact that when I move into the educational discussion and the collaborations that we have educationally, a lot of those have foundations, and I think Melissa mentioned this, in operational collaborations, right? So we have a lot of things that have evolved over many, many years. We didn't just jump in and say, hey, we want to come train your people, and many of the more advanced and sophisticated interventions and collaborations we have today, foundations were laid in those early days, and we built upon those as successes and wins, and established rapport and trust, and became a system that I think has a great deal of mutual respect. And I often tell people my biggest fan is one of the chiefs of police for HPD, and I am certainly one of her biggest. We truly have a trusting relationship where we value each other's partnership and realize the impact. I will say, in terms of the nature of those collaborations, we deliver the jail-based behavioral health services here in Harris County. So we have about, on any given day, between 7,000 and 9,000 people in our county jail, and we are the behavioral health services provider for that population. We also have a 100-bed dual diagnosis residential treatment program. We operate in collaboration with community supervision as a diversionary program. We have a CERT team, our crisis intervention response team. We actually have a joint team between Harris County Sheriff's Office and HPD. We all have formal MOUs that created that as a joint. It was approved by the City Council and the County Commissioner's Court. Together, we have 21 teams of co-responders where mental health clinicians ride with those law enforcement partners. We have a dedicated homeless outreach team with Houston Police Department where officers and mental health clinicians go out and proactively engage our homeless community. We have Crisis Consumer Stabilization Program, which is co-staffed between us and HPD, but you are put in that program by HPD because of a frequent utilization of 911 or a lot of interaction with law enforcement groups. We have Crisis Call Diversion, which is we've embedded crisis clinicians in the City of Houston's 911 call center. And so we take calls directly out of queue for dispatch and try and de-escalate them and avoid the ultimate law enforcement or EMS dispatch for those calls. We also have a core remote evaluation program where 100 Harris County deputies have tablets that they take in their cars with them, and if they go on a mental health call, they can pull that tablet out and connect with one of our clinicians remotely and we can do a mental health assessment is probably too strong of a word. Probably a crisis assessment or screening is probably most relevant, primarily aimed at helping that officer or deputy make some decisions about whether they can remain on scene or need to be transported. We are implementing a non-law enforcement crisis response team, so teams right now, like many communities are, as well as we have some diversionary programs. We have a pre-charge jail diversion center. We did do a sequential intercept map. If you get a chance, feel free to go to hcintercept.org, and you'll see that familiar sequential intercept map. If you click on it, you'll see all of our interventions at each point, at each intercept point, with a little bit of description there. One day I'll have some fancy pictures and videos, but for now it's just got mostly text on there. There's a few videos. I will also, it was mentioned already about collaborations and Criminal Justice Coordinating Council. I had the good fortune of them having the insight to include me as the county's mental health person leader in that meeting, and so I'm a member of that, and we have a mental health standing subcommittee of the Criminal Justice Coordinating Council here, and so that also plays in pretty large in this deal. Those formal collaborations should not be underestimated. So as we talk a little bit about the training, so first I'd kind of describe the formal interagency training. So we have a role in several law enforcement academies that are here, Houston Police Department, Harris County Sheriff's Office, Fort Bend, Webster PD has a training piece that they do, University of Texas. We also play a role in a couple of the citizens academies. We do have over 62 law enforcement jurisdictions in Houston and Harris County. So there's a lot of collaboration to be done and partnership to have. I will tell you, as the sole behavioral health entity, or at least the sole public behavioral health entity, it can get a little bit overwhelming at times, but I think it's critical, and it's broad and diverse. We have lots of others. When we talk about IDD, I've just kind of focused on some of the mental health components here. And many of these engagements are at responsive law enforcement agencies. They say, hey, can you come and talk to us about blank? And our answer is always yes. It doesn't matter who it will end up being. The answer is always yes, we're happy to. In addition to that, this is a picture. These are our team members. This is that joint operating team between Houston Police Department, Harris County Sheriff's Office, and our folks. The people that don't have traditional uniforms are our mental health team members and clinicians that are out there, whether they be co-responders or doing remote support work as well. That group always have a quarterly training for all of that team, and they invite people. They cross-train with each other. They invite people from the outside to come in. Harris Health, which is our public hospital, District Attorney's Office folks, Public Defender's Office has done trainings, our Public Health Department. It was already mentioned, individuals with lived experience. We always include those with any opportunity. I will tell you, we strive to have I talked about the CERT team where our mental health and law enforcement officers co-respond to 911 dispatch calls. We try and have recipients of those services, those CERT team responses, come and give feedback and talk about their experience with this group. It's invaluable learning to get that perspective of the person that you're impacting. We often think about the work we do and how we do it as opposed to the impact it has. And so it's been invaluable to get their input as having received these actual services as well, not just regular mental health services or non-specific lived experience. There's additional training opportunities, so related to NAMI, Mental Health America, Homeowners Association meetings, religious organizations, university classes, community health fairs, crisis management presented to other agencies. We've had some involvement with FBI-sponsored Joint Terrorism Task Force. We've done some training as a part of that. What you would find in almost all of those training opportunities where we go into those entities is you would almost always find one of our educators and one of the educators from our law enforcement partners. Seldom, in fact, I'm a little uncomfortable here today talking about this without one of my law enforcement partners being a part of this conversation. It's just kind of natural and intuitive that when we go and do these things, we do them jointly, we do them together, and make sure that everybody is engaged in that part of the process as well. A lot of, particularly the homeowners and religious organizations, and a lot of those come at request of public officials. So we'll have a council member call or a county commissioner call and say, hey, this group reached out to me. They have concerns. Can you go and talk with them and present with them? I've had an experience where I've been asked to present at a couple of different homeowners association groups, particularly where I happen to have locations where we deliver care. They sometimes get a little concerned. And remarkably, every time I've gone, without fail, I've had someone from the Sheriff's Office and from HPD participate and join me, and usually the DA's office as well. So even the hard conversations, they're willing to be a partner and be a part of those educational components and speak to that. And I think that's really, really powerful. I know with the Joint Terrorism Task Force, I think we co-presented with LA a couple of times on that, and so we also partner with other jurisdictions and other agencies as a part of those. We also do some pretty significant cross-jurisdictional training. We were one of the original U.S. Department of Justice and Council of State Government Justice Center sites, law enforcement mental health learning sites. We've had visits from Boston and Charlotte and Cook County. We've also had some that were perhaps not so voluntary. DOJ has directed some people to come and visit us, and those are sometimes a little more awkward when folks show up and they may not be in the spirit of learning and sharing and collaborating, but we do them. They're a part of it. We've also visited all those sites. We try and be as aggressive in our receiving of training and education as we are in offering. We want to be learning agencies and a learning community as well. So you'll also see we have hosted other Safety and Justice Center Challenge learning visits. We are a Safety and Justice Challenge grant recipient here in Harris County, and we have routine visits. This just called out El Paso and Santa Fe, Texas. You might recall from a few years ago, Santa Fe, Texas had a tragic school shooting. We had Denton, Texas. El Paso came specifically because they were wanting to think about replicating our 911 call, a mental health call response piece to that. There's a long list. I mean, I could have filled up more slides than any of us would care to look at with examples. But what we find typically is those visits are really related to someone trying to implement something in their community. And as I said, when we've implemented things, we've gone to other communities and try and bring back their learning. Inevitably, those things need to be tweaked a little bit, but it's nice to know you're not starting from scratch, that you're building on something someone else did. Usually the things I try and share more than anything are the things that I would do different if I had a chance to start over again or to take this from a ground-up approach and help them do something a little different than what we did in some cases. We also do cross-jurisdictional site visits. Some of the more common things that people have mentioned are pre-charge jail diversion, I mentioned, our outpatient competency restoration. We have a sobering center here, which just does tremendous work. The 911 call center piece, education transition center, ride-alongs, those are pretty common activities that we do from other jurisdictions wanting to come in and see what we're doing and what we're about and kind of how it works here in our community. There's also a fairly amount of conference trainings, both criminal justice conferences as well as behavioral health conferences. You can see some listed here. I will tell you, in almost all of those, I co-presented with some partner from the criminal justice system. Ironically, I did a recording, the Houston Bar Association Bench Bar Conference. There's another one coming up here soon. And this morning I did a recording of a webinar with the bureau chief, the mental health bureau chief from the district attorney's office. And so it's not always law enforcement. It is sometimes other components of the criminal justice system. But in these conference settings, we find that people, I think it a little more compelling to see both perspectives of this and why it's important and kind of the motive and engagement from each of the partners. And so we often, and I think almost all of these scenarios, did co-training where law enforcement and a mental health person were a part of the people doing those trainings, even in the conference settings. So, because really at the end of the day, it's about trying to make our whole response system stronger, sharing of information, creating a professional culture, relationship building, trying to create effective policy changes. We all know there's a lot of administrative and structural barriers to us working together and having strong collaborations, and it takes some work to get through those. They don't just happen easily. And at the end of all of that, what we have learned is that as we build those foundational pieces, then we can start to become a bit more innovative. You know, we can try a telemental health response with law enforcement. We can try a pre-charge diversion that very few places have tried to tackle in the country, and it's building on that trust, respect, rapport, and those other processes. We know we've done A, B, and C, so it's a small leap to get to D, as opposed to if we started with nothing, trying to get all the way to D would be probably impractical for us. So that is a lot of what I wanted to share with you today. I appreciate your time and interest, and at this point I'd like to turn it over to Sheriff Coppinger and allow him to talk a little bit about his presentation. Sheriff?
Well, thank you, Wayne, and good afternoon, everyone. It's a pleasure to be here. And I'm going to try and build upon what Melissa and Wayne just presented, because I think it's really applicable to what we do here in corrections, as well as what I did in my previous career as a police officer. And just real quickly, for those of you that are not 100% familiar with Massachusetts law enforcement, just keep in mind that a sheriff runs the correctional piece of the law enforcement component up here, and our cities and towns have, local police departments headed by chiefs, so they do most of the patrol work, the traditional police work, and corrections takes it from them. But the key here is what you've heard for the last hour or so, is cross-training and collaboration. Folks, this is not a one-dimensional problem. We all know that. We experience it. And unless we get our game together in a better fashion and look at this from all aspects, we need to look at it as a 360-degree problem. At least in my opinion, we're not going to fix it. We're making pretty good strides, but we got to do better. And if you think about it for a second, society in general, when there's a disturbance, or they don't know what to do, or they need help, they don't know who to call, they pick up the phone and they dial 911, and it's a police response. And doesn't have to be criminal. That could be anything at all, even a person acting out because he or she may be off their medication. And a lot of times, especially in past years, police officers may not know what to do, so they may resort to an arrest because there's nothing else they can do. They have to, maintain the quality of life and the peace and tranquility in the neighborhood. Somebody's acting out, it may be an arrest for a disorderly conduct or something like that, and they bring him into the station and they end up in court. And then oftentimes the court may not know what to do with the individual based on his or her record, behavior, pending charges, whatever it may be, and then that individual may end up in, a jail or a house of correction after conviction. So you really need to look at it, as I said before, in the 360-degree arena. When you heard my introduction by Ethan, he mentioned that I was the police chief. I was a 33-year veteran of Lynn Police Department. That's the largest city in Essex County. Essex County is just north of Boston with 34 cities and towns, but Lynn is the biggest city in our county. And I was chief there the last 7 years before I decided to become sheriff. One of the things that we implemented while I was in Lynn that I really want to talk about briefly was our behavioral health unit. This goes back several years ago, probably 7, 8, 9 years ago, where we collaborated with a local mental health provider, working with the State Department of Mental Health. And we brought in 4 clinicians and caseworkers into the police station to work with us, civilian individuals, expertise in their field. And I think it was Melissa was talking about trust building. I just want to give you a quick example of it. And for those of you in law enforcement, hopefully you agree with me, but law enforcement types are very skeptical of other people. It's the nature of the job. It's what we do. So when you bring in, outside civilians and you embed them inside a police station, the men and women in those blue uniforms that patrol the streets every day are going to look at them like, who are these people? And they're not going to trust them. They're going to be very apprehensive. So what we did was we gave the behavioral health unit an office right by the back door where the patrol force goes in and out every day. For the first couple of days, you could see there was no interaction, no communication. I just think this is key. But one of the young ladies who was one of our clinicians, she came in with a couple dozen homemade chocolate chip cookies, fresh. So when the aroma of the cookies hit that back door, those officers took an extra minute to go out and stop in and say, hi, how are you? I'm Officer so-and-so. And the collaboration began. And it really was successful. And the point of this all is, when you get that collaboration, we were able to go out and we service the folks in the mental health field that needed help. And we did it before they entered the criminal justice system. Now, I've always said that an individual police officer or deputy sheriff who patrols a city or a town or even a rural county, any officer worth his or her salt knows the good people on their route and the not so good people on their route. So they can, that's the true form of community policing. So they can really and truly then, adapt their reaction to the services that the individual needs. So having the behavioral health unit embedded with the police officers, going out into the community, going out on patrols with the officers. So when a crisis does happen, the behavioral health unit, individuals can address the individual in crisis, talk them down, de-escalate them, get them into a facility, get them back to a doctor's care to get them back on their medication, and keep them out of the criminal justice system, which is, I think, everybody wants to do in this day and age. And we had a lot of success with that. A byproduct of that also means less of those 911 calls, which allows the police officers to continue their patrol duties in a more proactive fashion to ensure public safety and keep our communities in better shape and increase their quality of life. So that's key. And like I said, we had some really good successes in that. So moving on a little bit, when we talk about what we're here talking about today with all the different groups and the different parts of the puzzle here with the collaboration, it really is, the key here is the data-driven approach. We have to keep, records. We need to know what we're doing, what we're looking at, and we have to keep analyzing it so we can increase our game and make better strides. The more we know about these problems, the better we can address them. And again, our goal here, now speaking as a sheriff instead of a police chief, is to reduce the amount of people we have in jail, send them out of here through our reentry system, which is pretty intricate. And as I like to say to a lot of the inmates when they leave here, particularly when they graduate some of our training and vocational programs, nice of you to stop in. No offense, but I never want to see you again in this jail. If I see you at a local Dunkin' Donuts or something, great, I'll have a cup of coffee with you. I'd love to do it. But we really don't want to see you back into the criminal justice system, particularly back in jail. So these issues are huge, and we really and truly need to find what are those best practices and search, our brother and sister agencies across the country. None of us have to reinvent the wheel. There's a lot of great ideas out there. So this collaboration that we talk about is so important, and that's why we just need to keep moving on and get it done and get it done correctly. So keep in mind, especially up here in the Northeast, and I know a lot of other parts of the country are affected, but we have a huge opioid epidemic. And so the substance abuse issue is key, as well as the mental health problems we have in society today. And a lot of our inmates here, a lot of people in society are suffering from both of these disorders. These co-occurring disorders are ruining a lot of people's lives. Real quickly, here in the Essex County Jail, we average our average daily population right now is about 1,000. It has dropped in the last 6 months due to COVID. But roughly speaking, probably about 70% suffering from substance abuse, and probably roughly about 60-65% have some sort of mental health disorder. As I said before, a lot of these folks have co-occurring disorders, so we need to try and figure out what is going on and how we can best address the individual needs while they're here in our custody. So for us, the big picture is, first thing we do is, when they come here, figure out, okay, what are we going to do? What's the treatment plan? What services are we going to provide? What is our goal, particularly with the pretrial folks, to see what we can do? And again, our ultimate goal is to prepare them for a successful reentry program, working with local partners. That is key. I mentioned it before. I will mention it again in a few minutes after I talk a little bit more about what we do. I don't know if it was Ethan or somebody that opened up the the webinar today, but mentioned about the grants. We are a recipient of a couple of the grants. This is our third Justice and Mental Health Diversion Program grant. Originally back in 2017, we were able to open up 8 beds specifically for some of this mental health pretrial diversion, and we're lucky enough now with that we're up to 40 beds, which is a huge boost to us to try again accomplish this goal of providing the needed services. So. As we jump forward, the Essex Mental Health Task Force, this is comprised of a lot of key players in the community. You can see on the screen the District Attorney's Office, probation, parole, the public defenders, community behavioral health and mental health partners, and workforce development. Going back to what I was talking about when I was working for the Lynn Police Department, there were a lot of providers in the community that were there for services, but a lot of times they didn't speak to each other. And a lot of times they may have been treating the same individual, not knowing the other agency might have been doing it. Now, is that legit? Maybe not. But when you get somebody on the street that's in crisis, it's not, it's not a care, the immediate care. The immediate care is to take care of the problem, the person in crisis at that moment. So this mental health task force we do here, when I was in Lynn, we were part of it here when the previous sheriff had it organized. And we continue to do it here. We meet quarterly, share notes, ideas, this data-driven approach. Think about what we're doing and who's got some new ideas and how we can better collaborate to put services into place. One of the things that we came up with and that we started here, a little while ago is the sequential intercept model. So what happens here is when somebody comes into our intake, the arrival day here at the jail, in addition to the standard booking questions, they also go through a brief mental health survey to see what the responses are and allow our mental health staff to focus on it and see where we can sort things out. It helps flag the inmates with disorders and guides them to the appropriate services that we're going to need with our mental health diversion program. couple of quick numbers for you. Since we started this, we've had almost 3,900 positive screenings or referrals. 178 of those individuals have been enrolled to date. And I'm very proud to say 116 successful diversions out to the community in a pretrial status, which is big. Now, you're probably saying, geez, Sheriff, there's only those, you're talking 178 numbers there, but you're talking about almost 3,900 referrals. Yeah, they were positive referrals, but it might not have been to the level that they might have needed the specific services we're talking about. But we also have a number of other programs here where we can help these individuals with the less severe levels of mental illness, in other areas here where we can get them the help and try to get them on the course. So we try to service everybody as we can. But for these numbers that I just gave you, I was focusing in on the ones that are grant applicable so that we can tie them into the data-driven process that we keep talking about. And out of that group, we have 31 that we call Track 2 participants who were diverted, who weren't diverted from the jail, but they were diverted into other programs that we have. And I would like to briefly mention two of these because it is part of the co-occurring disorders. One of them, which is our CASE unit, Clean and Sober Existence Unit. We've had it for a number of years. It's a detox unit, 28-day program, 42 beds for men, 42 beds for women. Working very closely with the drug courts. So if an individual, is in court and he or she is eligible to go in front of the judge in the drug courts, it's a collaboration not only between the judge and probation, but the district attorney's office, the defense attorney, the police officer, and also it's based on the charges at the current time. We don't take any serious crimes of violence or heavy-duty drug dealers, but we take most of the lower level charges here, and they bring them in, they go through an intensive 28-day program, and when they do return to court, they're accompanied by an individual treatment plan, working with those outside local providers so we can do a good, clean handoff and get these folks back out into the program. With the CASE unit, we've had a lot of good success using Vivitrol. Our numbers were pretty good. And in interest of true transparency, COVID has really hit it hard because the courts up here in Massachusetts have really were shut down for several months since early or mid-March, and they've only slowly reopened. But we're very optimistic those numbers will return. We're still going to keep our program running. We're down to small numbers there now, but they are growing now daily. That the program is back up and running. The other program that we started last September of 2019 is a medication-assisted treatment. I think it was Melissa might have talked about that. We jumped in as part of a pilot program here in Massachusetts. It was effective September of last year, as I mentioned. We now have embraced both maintenance upon intake as well as induction for those 60 days prior to release. In a year, I think we're about 36,000 doses. We have dosage units we've actually, administered to inmates. We built out a dispensary that's, to be honest with you, it's second to none. We spent a lot of money, but it was a grant program with a pilot program with grant money, so we spent it. And we got a pretty good system up here. Of course, it's not just the medications, but it's also the counseling sessions with it. Our healthcare is provided by an outside vendor, WellPath, and they partnered up with a local treatment provider called Acadia Health Systems here in Massachusetts. So our MAT program is up and running, full steam ahead. We've got some great numbers in there. It's been very, very helpful to us to get these individuals going where they should be going. Talking about the jail now and our staff, working in a jail is very different from working out in the street as a police officer. Obviously, we have a confined, area in here, and the inmates need help all the time. And mental health is an issue here. Combine just folks with mental illness out in the street, you put them inside a jail, now they're in a cell. The whole world is upside down. So we really and truly take a very close eye on the individuals to see how they react and live within a jail institution. So with some of this grant money, we have gone out and done mental health first aid training. As you can see from the screen, it's the National Council of Behavioral Health and the Missouri Department of Mental Health model. We did the Train the Trainer program. And all 520 of our correctional employees have been trained. We have a lot of other staff that do some other stuff here, but our core correctional employees that work day to day with the inmates have been trained, and their certifications are renewed each year. This is huge because now our officers can see what's going on. When they talk to the inmates, they can really, decipher the signs and symptoms of mental illness. We're not perfect. This isn't our occupation, full-time occupation, but they get a pretty good idea, and we have a great mental health team here that works with us, that's here 24/7. So if the officers suspect even a guy or one of the ladies may be a little bit off their game, as I like to say, all they do is make a phone call. We can have a mental health clinician over in that unit in a very short period of time to help them out. And if they need it, we have services. Obviously, we can take them back to our medical housing unit and get them further treatment or services as needed, just for their personal safety as well as the safety of the other folks in the facility. But that is huge, and we will keep that up. One of the other pieces that we have is the Crisis Intervention Team Training and Implementation. This is a DOJ program, working with the National Institute of Corrections. As you can see on the screen, it helps the officers understand and recognize the mental health disorders and how to de-escalate. What I like to tell our staff is, we don't pay you to fight. We don't pay you to wrestle. We pay you to control situations by de-escalation. Your best weapon is your mouth. Learn how to talk. Learn how to talk appropriately to someone that's in crisis, particularly in the mental health field. It really ratchets down the stress of the incident. We've had, again, some great success with this. Nobody has to fight. Nobody's going to get hurt. We get the individual calmed down. Mental health workers there together. We get them back, maybe back over to the medical housing unit. We get them the treatment they need. Get them back on their medications. Success, win-win for both sides. The other thing we're working on here is a trauma-informed care approach to corrections. We're looking to train all our staff on this, and understanding the trauma, the levels of trauma, what trauma does to the brain, to the personality, to the behavior. A lot of folks in here are from a variety of backgrounds, and some of it's not so good. If you can at least try to understand it, maybe empathize a little bit with it, and please don't think I'm a bleeding heart liberal, because I don't consider myself, I consider myself a realist. But when you see some folks here that may have been through some odd circumstances in their life, if they understand it and then they start to act out, if the officers can at least understand it a little bit, those same issues that I just mentioned about de-escalation and controlling a situation without having to go hands-on, as we like to say, really becomes important, and we can, again, a win-win for both sides. We can get the folks into the treatment that they need, or just get them adjusted. So that's the end of my presentation, folks. Again, I would like to thank you for having me here. It was great, and I'm going to hand it back to Ethan for the Q&A. Thank you all again.
Thank you, Sheriff, and thank you to the other presenters as well. I did want to remind folks that you can chat in questions into the chat box on the lower bottom right-hand portion of your screen. And certainly if you are taking questions at this point, if you'd like to do so. I would like to ask the panel a question. And I know that, Sheriff, you were just talking about it, and we certainly have heard about it in other jurisdictions, about the reductions in jail populations during COVID. And I think one thing that has come up is, or a question that's come up is there communities, jurisdictions seeing a rise in crises as people are being released, possibly without resources right there immediately? And if anybody in the group could speak to that at all, if they're seeing that.
I'll touch on that quickly. Our numbers were probably, be late February, early March. We were probably around 1,350, maybe a little more inmates, and we're down to 1,000. A lot of individuals. Number one, they weren't coming in because the courts were closed, and there was also a big push, obviously, to get more folks out of jail on a variety of charges. Some I was dead against, to be honest with you. They were taking some hardcore felons out of here. And a lot of them returned after, keep going back on the streets and then reoffending. But there were a lot of folks here that were coming out and then and going back to the community. So it's too early to really give you any hard data on it. But again, I think the point I want to make is the collaboration that we have with the local agencies. We have a policy here that every day when our inmates are released, we send we send an email out to all the local police departments, letting them know who's coming back to their community. So we're touching base with the local officers, letting them know who's coming back. As I said before, any cop worth his salt knows the individual. So they know they're coming back. Hopefully they're keeping an eye on them, because they're also doing a lot of these similar trainings. So it's something we thought of. It's something we're keeping an eye on, and let's just hope that we can keep our finger on the trigger on that one and keep it under control.
Great, thank you. So I see some questions coming in, so I'm just going to start as they come in. So first is to the panel. So what is the court's role with the mental health task force? Does the team just wait for agreement and collaboration and then present some agreements to the court, or is this preliminary to charging?
Both. Putting my old police chief's hat on, when you make an arrest and you bring the individual to the court at arraignment, quite often the presiding judge will order the court clinician to do a quick evaluation of the individual. Obviously, somebody with some severe mental illness issues at that time, they may be referred to a more of a secure mental health facility than a jail. If it's somebody else, that they can be referred back into the community based on the charges and the seriousness of the charges that they're being arraigned on, that'll be done. And then again, if they got to come up here, we'll do what we can with them. One of the things we do here in the county is try to keep a very good direct line of communication open with the judges themselves. Prior to COVID, we were doing the circuit, going to each of the district courts, sitting down with the judges, probation, court officers, even defense attorneys, bringing them all in, and we were just doing an hour-long Q&A, telling them about the programs we have, giving them the information so they can kind of tailor it to their clients or their, whoever's standing in front of the courts at the time, to work this thing again in that 360 collaboration as we talked about. So that's where it does. So we're trying to give the court options based on the individual, and the key is the individual's cooperation. And I think it was Melissa, and it might have been Wayne. Somebody mentioned families. That is huge when you're in the court. If the family's there to support the individual, that's a key component to a judge's decision on what they may do with the individual. That may go in favor of the individual, that may go against them, but as much information that collectively the groups can provide to the judges to make the proper determination for an individual at arraignment is key to what I think is key to that individual's success.
And I would echo the sheriff's comments. Sorry, Ethan, I would echo the sheriff's comments. It does seem to be both. Here in Texas, we're adapting to the Sandra Bland Act, which requires a mental health screening and a magistration order of a mental health assessment if they find a prudent lay person believes there might be a reason to suspect there's a mental illness. But then there's also the knowns, and then there's also the whole component where in our pre-charge diversion center, some of our goal is to try and stop these individuals from ever getting to a court. We would prefer, particularly on the pre-charge diversions are all low-level misdemeanors, 81% trespassing charges. Frankly, the rest of them are other low-level charges. So trying to avoid the whole presentation at court when possible. But in those other circumstances, then we also have the full kind of complement of specialty courts and mental health supports in courts, and we have court coordinators. We have a pretty robust system of engagement within the court system as well. So kind of all those points: point of entry, regular point of care. We have about 3,000 people every day on psychotropic medications in the Harris County Jail. So the regular in custody care delivery, the court, and then the diversionary aspects that are on the front end of the thing as well. And in our Criminal Justice Coordinating Council and the Mental Health Standing Committee, we have members of the judiciary in both of those. They regularly come to our meetings. They participate. They are some of the strongest advocates, frankly, for us to kind of get our act together and improve our system. So we appreciate their engagement and involvement.
Great, thank you for that, Wayne. Another question coming in. So for the panel, what is the nature of the trauma training for corrections? How long is the training? Is it a one-time training, or does it have different modules, refresher courses?
In brief, it's a 40-hour course given a week, and we give it 4 times a year in cooperation with the Mass Sheriff's Association, the total of 14 counties in Massachusetts.
And Ethan, we don't have a trauma training. Go ahead, Melissa.
Go ahead.
So I was just going to mention that at Policy Research Associates, we do offer a 4-hour trauma training for criminal justice professionals, and it's also offered by Policy Research Incorporated. And we also offer a train-the-trainers so that we can go in and across a day train local trainers on how to deliver that training. And it is just a 4-hour brief training, but a great introduction to trauma-informed responses to individuals with justice involvement, appropriate for criminal justice professionals as well as behavioral health professionals working with justice-involved populations.
Great, thank you. And Wayne, did you have something to add there?
I was just going to add that I'm going to steal the sheriff's idea and figure out how we go back and do trauma-informed education in our jail partners right away. We are doing some interesting work. We're in the process of trying to implement zero suicide in our jail, which is normally a healthcare approach to safer suicide practices and care. And so there's a lot of training and dialogue, and trauma bleeds into that a lot. Trying to have some awareness and responses that are appropriate to the context and situation. So, but not as directly, and I appreciate the sheriff's leadership in that area because it's critically important to those we serve. So, an idea I will steal from our panel here today.
Thank you. And this is a question for Mr. Young. The work you do with cross-systems training and the quarterly training events mentioned, how are these structured, such as how are topics chosen, and are they full-day sessions or a lunchtime?
Yeah, that's a great question. So I'll start with the last part because it's technical and easier. It's usually a half-day training in the morning, so it's kind of neither. It's kind of a blend. We have a training room that's large enough to accommodate those, and really it is the leadership of the 3 primary collaborative partners, the Harris County Sheriff's Office, Houston Police Department, and the Harris Center, and we work on what are the topics that we think have been coming up lately, what do we need. In some cases, members of our teams have said, it'd be really helpful if we understood more about X, and so we'll try and intentionally engage that. So it really is, even our topic selection is kind of a collaborative process of decision making and deciding what we think will be most relative and helpful. They have some standing things that we kind of revisit on a regular kind of annual basis to make sure we work in there, but most of it is collaboratively decided and agendized based on what we think will be most helpful. And I will say there's a fair amount of chocolate chip cookies, as the sheriff mentioned too, for that training. And it's amazing what a little bit of food will do for relationship building as well.
Great, thank you. A question came in about education and whether or not there were any type of specific or special types of education or credentials that could be recommended for college criminal justice graduates that are looking to do this behavioral health and criminal justice collaboration.
This is Melissa. I'm not aware of any. I think it's a great idea.
This is Wayne. We have not gotten to a place where that's a strong emphasis for us. I do think it is a great idea. However, we are beginning to get a kind of a sub-designation of peers in Texas, of peers who have involvement with the criminal justice system and have that lived experience. And so there is a specialty designation our peers can get, which is interesting that they're the newest kind of organized group in our system of care, but perhaps because of that newness, they recognize the importance of the justice involvement piece. It also sometimes can be a challenge to find peers who have that lived experience in that criminal justice involvement, but also meet the criteria to be able to be hired by a government entity and be working in some of these settings. And so that designation is also helpful for us in terms of identifying the talent that's available.
Great, thank you. And this question for the panel. Has anyone conducted cross-training for mental health providers that addresses the R&R model in looking at reducing recidivism as an additional treatment target?
So this is Melissa. Speaking back to my work in Mecklenburg County, we did have someone come and present to our criminal justice advisory group, which included behavioral health leaders and criminal justice leaders. And so she was actually previously affiliated with the University of Cincinnati. And so she did a presentation on R&R. And we then began an effort to look at the correctional program checklist as a tool to assess our local programs and how well they were serving justice-involved populations. And I'll say that it was a conversation we had to really dive into regarding really considering recidivism as an outcome that our treatment providers weren't used to thinking about. But we, through leveraging some of the resources from the University of Cincinnati and the correctional program checklist, we were able to really move the dial forward in terms of really thinking about addressing R&R across our mental health providers.
Thank you. Another question for the panel. Any suggestions on establishing buy-in to training or programs with resistant or reluctant police department, judges, other criminal justice professionals? I think probably to add to this question, and if there's suggestions from the panel on how do you address philosophical differences around this issue with agencies.
I'll take a stab at that one, and that is a great question. Especially in this day and age, let's just say of post-George Floyd and all the the movement across the country. One of the things that when we train our officers, we emphasize we're trying to make your job easier, more effective, and give you more time to concentrate on other things. So when we give them this type of training to look at mental health and to learn about it, as I said before, with the whole de-escalation process, we're really trying to make it easier for them because, 20-odd years ago, the old theory in corrections was just, lock them up, throw away the key until their sentence is done, and then shoot them out the door. I shouldn't have said shoot, bad analogy. Show them out the door. But seriously, it's the whole key here is, now with corrections, why we have them, they're here. Let's do what we can with them with the ultimate goal that they leave here in better shape than when they arrive. So again, they don't come back. And working with the community partners, I touched upon reentry earlier. I didn't really get into as much as I wanted to because of the time factor, but having good reentry services in the local community, especially where you have the bigger population feeds that come into the jail, and having those resources, those handoffs are important. When I talked about our substance abuse programs with the opioid epidemic up here, we can get the folks cleaned up in our case unit or get them stabilized on MAT. And then when we hand them off to the local providers where they can continue their treatment, that is key. And we have coaches out here, that help the inmates even after they leave in order to stay on track. It's almost like an AA or NA, not advisor, counselor. But it's just pulling the whole piece together and selling that to the officers at the time of training. And you got to throw some successes in there. If they see the successes, I think then they can relate it to their jobs day to day here, and then they get the buy-in. And once you get those successes, we just try to accentuate those as much as possible to send that message out that they won't come back to making the job easier.
Yeah, I would echo that. I would love to think that everybody engages because they want for the folks the same things that I want, but the truth is that isn't always the case. And so how can I help align what our motives are? So if their motives are to deal with this individual less, then let's talk about that. If it's faster, so the thing I tout, like in my diversion center, is law enforcement drop-off is 8 minutes. It takes far longer than that to book somebody in jail. So if your goal is to get that person off your hands and not have to mess with them anymore, I'm a part of your solution. So while I would love for everybody to hope for long-term recovery and stability and a meaningful life for these individuals, if it's the lowest common denominator is you just don't want to have to deal with them again today, then let me help you with that. And so however we align to their motives, wherever their motives are at and whatever their reasons are, then I'm happy to try to leverage that and create an opportunity there, even if it's not just kind of overall general wellness and well-being.
And I would add the importance of the peer-to-peer learning and training component. So where you might have a judge that is resistant, bringing in another judge from a different jurisdiction that is doing some collaboration that you would like to model after, and fostering a conversation between those two judges can sometimes open the door to considering more work. I've also seen where I've had a police chief very resistant to changes or collaboration, having the district court judge come to him and say, we are partnered with you on this. We are going to do this together as a jurisdiction. That opened the door to conversation and moving forward with collaboration. So, having those high-level people leverage their positional leadership and talk to each other can be another way to move resistant judges forward.
Great, thank you for that. Another question, Wayne, you had talked about, you mentioned non-law enforcement crisis response, and curious to hear from others on the panel as well, if they have thoughts on this. Can you talk about how calls, when they're coming in, how they're triaged for a law enforcement response versus a non-law enforcement response, as some communities and jurisdictions start to also look at these models and how they can provide the alternative to a police officer having to show up on a scene?
Yeah, I can certainly speak to kind of where we're at in that process, and we're still figuring that out. The head start we have is we had already decided in our community which calls we code them in the dispatch. So we identify them, we code them, we put them in queue for dispatch, and our mental health clinicians go into that queue, and they've got certain pre-approved codes that they can pull out. And so we've got a foundational component of which codes we believe we can de-escalate and avoid a dispatch altogether. And so the process we're going through right now is building on that set of codes to say, okay, we know which ones we think we might not have even needed to dispatch. So we know for sure if we can't pick those up on a de-escalation basis, let's send out our mental health response team as opposed to dispatching a regular law enforcement. But then which ones are on that next cusp, right? If you think about kind of concentric circles expanding, as we get closer into the center of that, what is that next layer in where we said, I'm not sure we're comfortable with nobody responding, so let's leave it unavailable to the mental health folks to pull it out of queue for dispatch and still dispatch somebody. And the other thing where we're really trying to think on right now, because as I described, we've got this kind of co-responder model, and then we've got this expanded piece where some of the patrols have tablets where they can reach us, and then we have a mental health response team, and then we have a non-response option altogether so it's trying to figure out how to connect that continuum of response options to a meaningful kind of triage and prioritization process. And we don't have that. I don't want to imply that we've knocked that wall down and we've got it figured out, but I'm challenging our people to not just say what requires a response from this group or that group, but how do we plan and prioritize thinking about the most intensive response to the least for what that call need is identified. So no different than as a behavioral health group, if you're one of my behavioral health colleagues out there, you triage and then begin to try and figure out what's the right level of care for this person, what's the appropriate level of intervention given the current situation. And so trying to do that same thing with this response continuum to try and make sure that if there's an element, and really it falls to us, a lot of it is danger. We have no reasoned approach to think that if there's an element of danger, if there's a weapon involved in that call, that we should be responding to that. That we're not a primary response if there's that in there. So that's probably a CERT team, if anything, right? And then backing it up. So that's the exercise we're going through now. We've got a little bit of a head start because we've already kind of wrestled to the ground what might not need a response, and might we be comfortable as a community having de-escalate and never have a response to. And I'll be honest, that started off as strictly law enforcement, and our friends from the fire department and EMS said, no, you don't understand what we do. No, thank you. You just deal with your friends in the police. And it was about 3 months when they came over and said, that's a lot of diversions you've had. What if we could do a few of our calls not having to respond to it? So, success begets success, and I think we'll have a little more of that as we go through this on those others. But that's exactly the question we're wrestling with right now. And we've got some parameters, but it is very much a moving target for us in this process as we go through it.
I just want to
Great,
say,
thank you for that.
I just want to say,
go ahead, Sheriff.
I think Wayne just hit the nail on the head with that answer. That is right on the money, and that's the perfect approach, at least in my opinion. Congrats to you guys down there. That's awesome.
and this is Melissa. I want to also mention for those who may be interested in just looking more at a specific program, the CAHOOTS program, CAHOOTS. So they are functioning in partnership with their local police department, but they respond to requests made through a non-emergency police line. And so it is dispatched through police radio, but it's a non-emergency line, and they are able to respond without a police presence. And so that's also something to explore if you're just getting started and just need to maybe look at a program model.
And I think LA's got a model too. There's a few that have popped up. Austin here has begun doing it. So there's some, and we're probably all doing shared learning for the most part at this point. Code seems to be the most developed, but at least you're not in it alone, right? I think most people are willing to share.
Great, thank you for that. I am looking at our time. It is 3:30. Has come to the end of the webinar. I do want to thank our presenters for today, and certainly want to thank everyone who has participated in the webinar. Be well and stay safe, everyone. Thank you.